Good afternoon, everyone. My name is Carrie Nixon. I'm the CEO of Healthcare Solutions Connection, and I want to welcome you to our webinar this afternoon, Not So Affordable Healthcare, the Impact of the ACA Insurance Mandates on Providers. I wanted to let you all know that this webinar is being recorded, and it is my pleasure to introduce to you Ann Carter and Scott Polanski, who will be guiding us through the webinar today. Both Ann and Scott are experts in our Healthcare Solutions Connection network. You can see that Ann, who is joining us from Nashville, Tennessee, her hometown today, is president of Healthcare Change Consulting Group with over 30 years of experience in the industry. You all can take a look at her wealth of experience and expertise on this slide. She has worked with any number of medical centers, community hospitals, critical access hospitals, and has significant expertise in healthcare strategy and operations. But Ann was most recently a regional vice president at Quorum Health Resources, and Quorum is the largest hospital management company and 10th largest healthcare consulting company in the country. She has been at Vanderbilt University Medical Center and has additional experience with other health systems, including post-acute care, and has taken part in healthcare education. Scott Polanski is the principal of Polanski Consulting Group and is joining us today from the Boston, Massachusetts area. Scott is an expert in health insurance. He was very much involved with the Massachusetts and the Vermont health insurance exchanges, and formerly served as Chief Business Development Officer for Boston Medical Center HealthNet Plan. Prior to that, he was the Director of Product Management for Harvard Pilgrim Healthcare, where he focused on product development and benefit design with a specialty in consumer-directed healthcare. He developed product strategy for HPHC and comes to us from Hobart College. So let me take a moment now and let you know that we will be accepting questions with respect to anything that you all have for the presentation. And at any point, you can look to your left and see that there is a chat box. And you can type your message into the chat box, and at the end, we will take questions as they arise. Let me actually pause for a moment and ask the participants, can you all hear me all right? If anyone cannot hear me, can you please type a message in your chat box? All right, I'm going to turn it over then to Scott Polanski to lead us through our agenda. Scott?
Thank you, Carrie, and thanks everyone for attending today's webinar and giving us the opportunity to share some of our thinking about the ACA and the impact on providers. So for the agenda, I'm going to provide more context and background, walking through some basic definitions around the ACA, and then get into some more specifics about the advanced premium tax credits and how those work for enrollees, as well as the other piece of the subsidy pie, which are the cost-sharing reductions. And then I'll wrap up my part of the presentation by sharing some enrollment statistics to give you a flavor about how the enrollees are falling out nationally in terms of which plans they're providing, what levels of subsidies they're getting. And I'll let Ann describe her part of the agenda at this moment.
Thank you, Scott. Well, I am going to be talking more about the providers and how some of these issues are affecting providers across the country. I'm also going to be talking about the Medicaid expansion and the impact it's having on providers. Obviously, the states who have expanded their Medicaid options have really had a very positive impact on providers. I will also be talking about the increase in bad debt with providers across the country, and I will be talking about some steps that maybe we can think about or discuss or take toward a healthier revenue cycle for providers.
Thanks, Ann. So I'm going to jump into some basic definitions, and you've probably seen or heard about most of these, and just wanted to share some of those specific definitions and give you my comments as well. So actuarial value has been a common term, and that is described as, or defined as, the percentage that insurance companies will pay on average, and that's the key concept there, is on average, for the health services consumers use. Consumers will have to pay the balance through coinsurance, copays, and deductibles. So again, that's on average. So that's the actuaries doing their fancy math, and obviously for any individual, it could vary tremendously in terms of what they might pay out of pocket, but this is just an average calculation. QHPs, or qualified health plans, those are private health plans offered on marketplaces, or also known as exchanges, that must cover an essential set of health benefits, the EHBs, which include, as an example, mental health, preventive care, pediatric, dental. An important point is that these qualified health plans that are offered on the public exchanges must also be offered directly by carriers at the same rates as that are made available through the public exchanges. Metal levels. So these are types of QHPs offered which vary by the actuarial value. And the basic concept is that as the premiums increase with the actuarial value, the cost sharing decreases. So for example, the platinum plans cover 90% of average covered costs, all the way down to bronze plans, which cover 60% of the projected total cost. So for a bronze plan, those have the lowest premiums, but the highest cost-sharing levels. So, and I'll talk about that later on in the presentation, about what the trade-offs are between higher premiums and lower out-of-pocket costs. Another common acronym out there is the FPL, which is the federal poverty levels, which are the amount of annual family income, which basically varies by region and family size. So the more family members, the higher the FPL. And the FPL is used to determine how the APTCs and CSRs are used. So just to put it into context, to give you some examples, for a family size of 1 as an individual, for 2014, the FPL was $11,670 at 100%. And that, you can see that increases all the way up to $46,075 at 400% of the FPL, and that's a linear relationship. And then you can see in this, the tables are out there that have all the different family sizes. I just want to give you a flavor for a couple, and you can see that for a family size of 4, the 100% of the FPL is almost $24,000, and it goes all the way up to $95,400 for 400%. So the bottom line is that people making less than 400% of the FPL based on their family size are eligible for subsidies. So what are those subsidies? The first one I'm going to talk about are the APTCs, or Advanced Premium Tax Credits. Those are based on projected annual household income. That's an important point. When people come to these exchanges and go through the application process, they provide their projected annual household income. It's not just if it's a couple, they need to put both couples' incomes on the projected income. And there is a reconciliation at the end of the year, or for the next tax year, there's a reconciliation. So if people overestimate their annual household income and it ends up being less, then they could get a refund. Whereas if they've underestimated their family income, then they would have to pay back some money. The way the premium tax credits work, it's based off of the second lowest cost silver plan in the market for that particular area, and that's called the benchmark plan. And the point about the APTCs is that the enrollees can buy up or down. So basically they get an allowance, and a silver plan, they would pay less for their out-of-pocket premium costs, as opposed to if they wanted to enroll in a platinum plan, they would have to pay a lot more out of pocket for the premium plan. And important point also is that the APTCs are paid by the federal government to the exchanges who reimburse the insurers for the value of the APTCs. And then there's a reconciliation at the end of the year. So just as some examples of how it works, the advanced premium tax credits, the goal is really to limit households to paying no more than a certain percentage of income on their health insurance coverage, where any excess above those thresholds are covered by the credit. So you can see for somebody making 100% of the FPL, that's approximately $12,000. The formula says that no more than 2% of their income can go towards health insurance premiums. So that's about $12,000 for somebody at 100%, or at 2%, that's about $240 annually. So that's about $28 per month that they would be paying for premiums, and anything above that would be an advanced premium tax credit. And another important point about the advanced premium tax credits, and obviously because it includes the word advanced, these tax credits are able to be taken during the year in which they're receiving coverage. So while the reconciliation will be a year hence, the premium tax credits are paid in advance if somebody wants. They can elect to not take the advanced premium tax credits and wait until they file their taxes to collect the actual tax credit. As I said, the APTCs are reconciled on an annual basis, and there are some limits on how much somebody would have to pay back. I mean, if they're in a lower FPL class, like 125%, there's strict limits on how much they'd have to pay back. A very important point here, this has been getting some press recently, is that because there's all this discussion about what happens with enrollees, whether they are automatically re-enrolled or should they have to select a new plan every year. Right now, it's an automatic re-enrollment process. So what could happen is if somebody's in the benchmark plan this year, then they're getting a certain amount for their APTC. If the plan they're in this year, for whatever reason, the premium changes, let's say, and it increases to a gold plan, and the person doesn't do anything, their premiums are going to go up significantly, but the APTC is really fixed. It's going to now be calculated off a lower cost silver plan. So the important point is that people really need to look at the plan they're in this year and where it falls in the premium hierarchy, if you will, for the coming year when they make their enrollment decision. And also a huge issue is, I'm sure many of you are aware, is whether the APTCs will end up being available to enrollees in states on the federal exchanges. There's been some mixed rulings out there, and right now the majority of states are on the federal exchange. So if the rulings come down that people can't get subsidies if they're in a state that is using the federal exchange, that will have obviously a tremendous impact on people's ability to get affordable insurance. And that will impact a lot of what Ann will be talking about in a few minutes. So let me switch gears for a second and talk about cost-sharing reductions, which also the anagram there is CSRs. And these are additional subsidies that are available to a subset of the folks who are receiving the APTCs. So the APTCs go up to 400%. The CSRs are only available to individuals with household incomes up to 250% of the FPL. And another important point here is, and I think there's a lot of confusion out there among potential enrollees, is that the enrollee must be in a silver QHP. So I talked earlier about when you get the advanced premium tax credit, you can still, as an enrollee, elect to enroll in the full menu of available QHPs. That's not the case for the CSRs. In order to receive these CSRs, you must be enrolled in one of the silver level qualified health plans. And there are 3 levels of CSR. And again, the silver plans are at 70% of the actuarial value. So what the cost sharing reductions do is, in essence, they keep the person's premium fixed, but they make the plan designs richer so that the cost sharing for these members who are eligible for the CSRs actually decrease. So for somebody who's making 100 to 150% of the federal poverty level, their actuarial value goes up to something north of a platinum plan, which is 90%. So again, they're paying a lower premium at a silver plan, but they're enjoying benefits which have reduced cost sharing. It brings it up to the actuarial value of a platinum plan. And you can see that depending on where their FPL falls, they can still get 73% AV or an increase of 3% there. So let's see. And just to clarify also, you must be in a silver plan. You cannot enroll in a bronze plan. So it's only the available silver plans as defined by the state exchange. So you can't buy down, can't buy up. It must be only within that metal tier. Let me just give you an example too. This was from some plans in New York in terms of what does it look like to have these cost sharing reductions. So there's a standard plan right there, the 70% AV, deductibles, $2,000 maximum out of pocket is $5,500 for an individual. Inpatient hospital copay is $1,500 per admission, and the physician visits are $30. So let's just pick the CSR in the middle, the 151 to 200%. It's an 87% actuarial value. The deductible goes all the way down from $2,000 to $250. The maximum out of pocket is only $2,000 instead of $5,500, and the inpatient hospital copay is reduced from $1,500 to $250, and the copay is halved from $30 down to $15. The health plans in each state have flexibility about how they put these cost-sharing reductions together as long as they can get to that AV level. So that's the key. So in some states, you might see a significant drop in the deductibles and no changes in any of the other cost sharing. Other states might be more similar to New York here, where they're changing most of the or all of the components of the cost sharing available to them. So just a couple other points about the cost sharing reductions. They are reimbursed directly by CMS for the projected value of the CSR. That goes right to the insurers from CMS. There is nothing that flows from the exchange to the insurers. This is simply between the insurers and CMS, and there is an annual reconciliation, and there's a lot of consulting firms out there making a lot of money helping the insurers figure out how to do these different reconciliations. And the good news from an enrollee's perspective is they do not have to be involved in any way, shape, or form in the reconciliation for the CSR. That's totally between the government and the issuers. And you can already see there's a pretty, if you're at a lower FPL level, you get a pretty rich benefit design. And above and beyond those plan designs from the federal cost sharing reductions, a number of states have also decided to fund some additional dollars to provide even further reductions in the cost sharing available to enrollees. And just as a data point too, before I jump into some other ACA statistics, about the data showed in Michigan, I saw a survey that said of the people who are eligible for the APTC subsidies, which is about 85% of the people, as you can see in the second bullet here, they found in Michigan that 2/3 of those folks were eligible for the cost sharing reduction. So again, 85% of the people are making up to 400% of the FPL, and that means about 2/3 of those folks are making up to the 250% of the FPL. The important point also in the second bullet here is that while 85% of the people who got coverage were eligible for credits that year, in the Kaiser Family Foundation survey of the uninsured in California found that 73% of those eligible for assistance did not know they could get help. Other important point is that the uninsured need to know that the penalty for going without coverage increases substantially next year to $325 per person, or 2% of income, whichever is greater. And the data show that 2/3 of the folks are aware of that. And last point, and then I will turn it over to my colleague Ann, is that so the question is, how much are these subsidies? We know 85% of the folks out there are getting subsidies. The average APTC, not the cost sharing reduction, but the average APTC was almost $2,900 for the average enrollee in 2014. And, a couple more slides. Just also wanted to share with you, so what's the distribution of enrollees among the metal tiers? So no surprise, at least to me it wasn't, the majority of people are in the silver plans, that's 65%. And then you can see in the bronze plans, it's 20%, and the gold plans are 9%, platinum plans are 5%. There are these catastrophic plans available to people under 30, and those have about 2% of the enrollees in them. So at this point, I want to turn it over to my colleague, Ann Carter, and I look forward to entertaining any questions at the end of the session. Thank you.
Thank you, Scott. Well, the ACA is moving the nation toward full insurance coverage, as we just discussed, but why is that becoming such a problem for healthcare providers? Let's talk about who is on your revenue cycle headache list, and I'm sure there are many. First of all, we've got the people on the exchanges who are insured, and they walk in your door with their new cards, but they have very high deductibles, and many of them might as well not have insurance when they first walk into your emergency room. Then we have the out-of-network insured. These are people who maybe don't understand the limitations of their narrow network, or they are coming to your hospital and the hospital's in the network, but maybe the anesthesiologist isn't, or the radiologist isn't. So we're seeing a lot of problems there. We also have the employer-insured people, but they too have high deductibles. And in fact, 1/3 of employers will offer only high deductible plans in this next year. Then we have those traditional Medicare patients who can't afford Medigap or don't get Medigap insurance, or don't enroll in an Advantage plan, or don't have support through Medicaid. And those folks are paying pretty high deductibles and copays, and many of them really can't afford it because they're on fixed income. Then we have newly insured people. They get on the exchanges, they're excited, they seek care, but it turns out that for some reason they're dropping the insurance, maybe they can't afford it, or they are being dropped because they perhaps can't prove citizenship or meet the standards for providing financial information. And suddenly you have a person who perhaps has had surgery or some other elective procedure who is now back to being uninsured. We also have those uninsured that fall into the black hole between the Medicaid FPL and the subsidy FPL. And these are people who are in the non-Medicaid expansion states. So they're people who normally would have been covered under the new Medicaid expansion up to 138% of the FPL. And they're single adults without children that normally wouldn't have been covered by Medicaid. But if they're below the 100% of the FPL, they are not eligible for the exchange insurance subsidies. So they're people who are definitely in a black hole. Then we have the uninsured, who are going to be uninsured probably for any length of time due to their citizenship status, or the fact that some people are just not going to buy insurance. In fact, there was a study that indicated that 25% of people may not comply. Now, as we see, as Scott mentioned, as we see the mandate causing people to have to pay a whole lot more in order to offset the fact that they didn't get insurance, we'll probably see that statistic change to some degree. But there has been so much steady growth of high deductible plans since 2005. In fact, they've been growing by about 15% a year by 2013, and we now have 15.5 million people in high deductible plans, mostly right now from employer-sponsored insurance, but many of the people who signed up on the exchanges are taking the high deductible plans because the premiums are so much less. In fact, 81% of employers are now going to be offering at least one high deductible plan in 2015. And then the uninsured are also paying a huge portion of out-of-pocket costs. If you look at what is expected of an uninsured person, they might pay as much as $500 of their per capita medical spending toward out-of-pocket costs, and while the insured person is paying about $620 or $610. So not so different, except that the uninsured person, that's 20% of their total expenses, whereas the insured person, it might be only 12%. So a huge burden on the uninsured person. And of course, we have traditional Medicare, and fortunately, many people in Medicare have opted for Medigap insurance, but there are 14% of people who are not getting any other support, and they have very high copays and deductibles as they utilize services. And let's not forget that the fastest growing segment of the population are people 85 plus, and they really are going to spend enormous amounts of time in hospitals and physician offices. And Medigap is a wonderful thing for many seniors, but it provides even first dollar coverage. But the problem is that the government is now looking at Medigap and saying, well, maybe seniors need to have a little skin in the game. And so they may take away that ability to have that first dollar coverage. And of course, there are the uninsured, and there will always be uninsured with us, but the uninsured rate this year fell to 13.3% by 42 million, or down to 42 million people by the end of June. That's the lowest rate since 2008. And 10 million people have gained coverage in 2014, so it's a huge jump. The uninsured rates in the Medicaid expansion states fell from 18.4% to 15.7%. And that's exciting, except that those people in non-expansion states, there was no change in the uninsured. The uninsured rates for Hispanics and African Americans fell by 3%, and that was important because those were the two highest groups of people that were uninsured previously. And the CBO is projecting that 7 million additional people who have been uninsured will gain insurance during this new enrollment period. But let's face it, in 10 years, according to the CBO, 11% of the population, or 31 million people, will still be uninsured. So let's talk about the Medicaid expansion for a minute, because that has had a huge impact. When the ACA was initially developed and when it was initially passed, every state was required to expand its Medicaid program. But when the case went up to the Supreme Court, as you I'm sure all remember, the Medicaid the decision was that states did not have to expand their Medicaid programs. In the states where there has been expansion, there are uninsured The uninsured, the volumes are decreasing. The uninsured use of the ED is decreasing. It's really significant. For-profit hospitals saw significant change by the second quarter of 2014 in uninsured admissions. Amazing that the huge drop. The reason that we're looking at the for-profit hospitals is because they have to publish all of their data quarterly, and the Office of Health Policy did a study just to try and get a feel for what's going on in 2014 with insurance, and they had to use the for-profits primarily to gauge what they think is happening. Community health systems and HCA are the largest for-profit chains in terms of numbers of hospitals. Then we have ED visits, and they have definitely fallen for the uninsured, but in the expansion states, not in the non-expansion states. So we are seeing a difference, a tremendous difference in the impact of Medicaid expansion on the uninsured. This same study looked at uncompensated care to try and get a feel for what we could expect in terms of reductions in uncompensated care. And they defined uncompensated care as charity care plus bad debt. They didn't follow the strictest definition according to the government for the dish payments, but they did look at hospitals uncompensated care based on charity care and bad debt. And in their study, they predicted that charity or uncompensated care will go down to $28.2 billion from $33.9, and that should say billion in 2012. So you'll see also in this graph that the non-expansion states have less or are going to carry more of a burden, less of a reduction in uncompensated care. The study also projected that there would be that $5.7 billion reduction in uncompensated care, mostly in charity care. But if you will note, the expansion states will see a much stronger reduction than in the non-expansion states. Charity care. I think as we look toward the 2014 and 2015 results of this analysis, we would see a bit of a different picture. We're going to see less charity care, especially in Medicaid expansion states, and we will probably see more bad debt. So let's look at that. Why do the insured that walk into your hospital or physician office look like the uninsured in your revenue cycle? Well, a lot of that has to do with the rise of bad debt. And we are seeing a tremendous increase in bad debt. If you will note that uncompensated care, the primary place of service for uncompensated care is the hospital. But there is a tremendous need across all providers to deal with this problem of high deductibles and the need to deal with and find ways to handle the high level of bad debt. The average recovery rates for bad debt in 2013 was only 15.3% for hospitals and 21.8% for other healthcare providers. And hospitals reported 5.9% of gross revenue was written off as charity care or bad debt in 2014. In 2013, that was 6.1%. And the equivalency of bad debt and charity care in the first quarter of 2014 was approximately the same. In 2013, 58% of covered workers at small firms, up to 199 employees, had a deductible of $1,000 or more. We expect that to jump up as suddenly the small firms will be required to either provide insurance or let their workers go to the exchange. There is also a tremendous change in the enrollment in consumer-directed health plans with high deductibles that grew from 39 million to 45 million in 2013. But really, the people who have high deductible plans are really struggling with it and having difficulty paying their medical bills. At least, if you look at the people with high deductible plans, over a third were having difficulty with either paying off the medical bills or paying them at all. And over 80% of people getting insurance on the exchanges in 2014 chose high deductible plans. At least a third of patients had difficulty paying their bills in 2012. And so the good news and the bad news. Good news, 20 million new patients will join the healthcare system by the end of 2014. There's going to be more volume, more procedures done, because people are coming into a system where they have not been covered and have not done any kind of elective. The preventive diagnostics and treatment that the government now says have to be covered without copays and deductibles. And we should see a lot of the patients taking advantage of that if they are aware that that is available. But the bad news is that the government is going to reduce payments for uncompensated care, and those are the DISH payments and the UPL payments, and the government has set certain targets for reducing them. Now, supposedly they will look at how many people in a particular state or an area are still uninsured in order to determine what those reductions in payments will be, but there is a target to reduce those payments. Then over 80%, as we mentioned before, of those insurance exchange enrollees chose those high deductible plans. 1/3 of all U.S. workers have high deductible plans, and the out-of-pocket payment is pretty significant. It's over $6,000 for individuals and $12,000 for families. And people just don't have the money to pay medical bills if they're under 400% of the poverty level. Now, remember that was almost, for a family of four, was almost $95,000, but people still don't have the assets. And when we talk about liquid assets, we're talking about checking accounts and other, basically your cash. But the net financial assets are, after you take your consumer debt and your unsecured consumer debt and look at your liquid assets and your unsecured consumer debt, you're looking at people who have negative financial assets. And even though the people at 400% have $5,200 in net financial assets, that's not much if you have a deductible of $6,000 that you have to meet. And most families just can't afford anything that is critical that goes over 5% of their income. So if you look at medical care, they would not be able to pay their out-of-pocket expenses. 13% of them would not be able to pay it if it's over 5% of their income. So we have a lot of people who have insurance but really can't pay for it. And then we have people who are having difficulty paying their medical bills that are employed. So we have 54% of those folks who have difficulty paying that are actually employed and have had insurance and continue to have it. So what is a healthcare provider to do? You know, this is not an easy answer, and obviously we're happy to have people finally insured, but how do we deal with that? Well, let's talk a little bit about two important task forces that have been set up to deal with some of the issues around this new level of consumer cost sharing, really. The consumers are suddenly saying, I want to know more about what am I going to pay, and they're going to be shopping. The HFMA was created to look at how can we be transparent if we are in the healthcare industry regarding pricing. And it's very difficult to do because we have a very Byzantine form of pricing that really doesn't connect with the cost of providing services. The recommendations were that health plans should help members estimate their out-of-pocket costs, and a number of the major health plans do have those estimators. And they should also provide price information on alternate providers if possible. But hospitals should be guiding uninsured patients into information about possible insurance options. I mean, if somebody walks into your emergency room, chances are they don't even understand how to use the exchange. Hospitals should publicly communicate those financial assistance policies, and they should direct uninsured patients to information on price estimates. So trying to get to the bottom of what is it really going to cost someone and what can they afford. Now, I thought this comment by Karen Ignagni of the America's Health Insurance Plan organization was really a telling one. She said when they did this report that it hit us over the head that we have transitioned from the issues of access to the issue of affordability. Now more people have insurance, but can they really afford to utilize it? The other task force is the one that was created by HFMA and ACA International to deal with the medical debt collection best practices, voluntary guidelines, so that the people that have been, there has been a lot of concern about how collection agencies operating on behalf of medical providers have been very aggressive and have created a lot of issues, not just for the person who is dealing with the debt, but for the providers who basically have gotten a black eye because of these aggressive policies. So the task force is some of their best practices, discuss improving patient education and communication and doing that on the front end, making bills patient-friendly, and that's really important as consumers start to look carefully at what they're paying for, and establishing strong and good policies for account resolution, making sure that when an account is resolved, the credit bureau is informed so the consumer gets their name cleared, and tracking all those consumer complaints about aggressive procedures. If we follow those two task force recommendations, we can also look at the fact that so much of what we can accomplish in helping one of our patients achieve or be able to pay for their services has to do with the way we treat them, talk to them, and educate them on the front end. And a lot of that can be done by your people in registration or financial counselors that you bring in to assist them. But we definitely have to make sure that we have opportunities in place for people to gain some discounts, to have incentives for them to pay up front, or have payment plans that will allow them to pay over time. We need to educate people about health savings accounts. If they already have a high deductible plan, they might be able to team it with a health savings account and use pre-tax income to pay for a lot of those costs that come with high deductible plans. If you have patient liability calculators to help somebody see up front, oh, this is what I can expect to pay, it really takes that shock level out of the situation. And also guiding patients to price transparency tools so that people can say, oh, okay, I now understand what I'm paying at this hospital or in this setting, and the next time I need to go to an alternate setting or an alternate provider. And to post information about those cost reduction subsidies that Scott talked about. Many people don't realize they have to sign up for a silver plan if they're going to get them. You can also consider applying for a Navigator grant. For example, the University of Mississippi Medical Center received $831,000 for their grant, and they were able to deploy financial counselors throughout the communities that they served. They were able to do all kinds of education. They really became the conduit for which people could gain insurance help. But if you can't get a grant and they may not be available for 2016, they've already been awarded for 2015, then you could look into becoming a provider that is considered a certified application counselor, which means that you're not doing your requirement to gain this status is not as rigorous as becoming an actual Navigator organization. But it does allow you to deploy financial counselors to targeted community organizations or other areas of the community. And it does give you the opportunity to provide education programs and to put counselors in settings where people are first encountering the need to possibly pay upfront. And what, in a recent study by the advisory board company, they looked at what kind of hospitals are collecting revenues up front. And if you'll note, there isn't a whole lot of revenue collected up front still, but the really high-performing hospitals tended to do it much better and much more often in order to get their revenue cycle in line with something that they can that will add to their bottom line. Then make sure that you align your policies with best practices. Have clear, transparent policies. Make sure that they are posted. Make sure that you're clear with the patient. If they have a high deductible, will that balance that they have to pay? Will that come in under your financial aid plans? Make that clear. Make sure that if there's an elective admission that you're asking for some financial payments up front if the patient has financial responsibility. Evaluate outsourcing some of your revenue cycle if it's very difficult for you to do everything that you would like to in order to assure a strong bottom line. Develop policies for those who refuse to sign up for insurance on exchanges or for Medicaid if eligible. In other words, you know, if people say, well, I just didn't get insurance, I really didn't feel like I could afford it, then you have to decide as a provider, are we going to allow them to participate in charity care, or are we going to allow them to participate in our financial plans that we've created for people who truly can't afford care? And make sure that your charity care policies are public. And don't forget to really revisit your revenue cycle processes very, very often, because it's easy to become complacent and assume that you've done everything you could and that everything's running smoothly. Make sure you're staying on top of all the accounts that are problematic. Make sure that you've got the right collection agencies in place, or that you're doing it well within your organization. Make sure you're following those HFMA guidelines. And continue to look at new technologies that will help you in ensuring that your revenue cycle processes are up to date. There's great new software developments that can assist you, and there's the biometric authentication processes or equipment that can be used to determine if someone is actually the person that they present themselves to be. Make sure that patients have multiple options to pay, be it check-in kiosks or online payments. Give them as many options, make it as accessible, and make it as easy to do as possible. And then think about population health in your revenue cycle. You know, usually those are kind of two separate areas of a health system or a health organization. But if people have high deductibles and they have difficulty paying their medical bills, who better to discuss your chronic disease management programs with? Give them some information on how they can do more to control their own health issues. Provide them with information on health monitoring apps that are available on their smartphones. You know, they can track their own health conditions. They can gain encouragement to exercise, to track their diets, to even stop smoking. And start that education process about where do you enter the healthcare system when you're ill, and trying to get them moving away from the emergency department and into more community settings and physician offices. And don't forget to distribute materials about the kind of things that you're offering under your population health management efforts, and make that available during your financial counseling sessions. The key here is to engage patients whenever possible in accepting responsibility for their own health care and its impact on their financial health. That can make a huge difference as people look at their high deductibles and think, oh, great, I have insurance, but I can't afford it. So with that said, I'm going to turn it back over to Scott to talk about his takeaways.
Thanks, Ann. Great job there. So just a few things to highlight. So obviously the issue about the ACA success is going to be tremendously impacted if these challenges to the subsidies for the states that are using the federal exchange do end up becoming reality, that they are overturned, I should say. still continues to be much confusion, misunderstanding about how the ACA policies and requirements work, both from an individual level, from a provider level, from an employer level, both small group and large group. And as Ann pointed out as well, I mean, the mandate of coverage and the essential health benefits and the elimination of medical underwriting have led to a large increase in when I say covered lives, I mean truly covered lives. A lot of these mini-med or minimal coverage plans have been outlawed, and I think when people had those, there was a lot of specious coverage anyway. So I think by having the essential health benefits and these qualified health plans that are approved by the feds in the state, that people are really getting much more reasonable coverage than they have in the past. And Ann, that's all yours.
All right, and I think some of the takeaways from what I just discussed is that, you know, we just do have a major problem with increased provider bad debt, and that's not going to go away. We just have to find better ways to cope with it. We also have to look at provider or Medicaid expansion in states, and if Medicaid hasn't expanded in your state and you as a provider are concerned about it, then one has to consider lobbying efforts to try and make that change. But the fact is that the states that do have Medicaid expansion are really doing so much better in terms of dealing with the uninsured. And then there are ways to meet the challenge of higher patient cost sharing through some of these best practices that we described by FMA and ACA International. And finally, that providers have to become educators for patients to help them understand how their financial health is critical to their overall health. So with that said, do we have any other questions?
Ann and Scott, this is Carrie Nixon. I want to thank you both for an incredibly informative presentation. I certainly learned some things that I wasn't aware of. We do have a couple of questions, and let's see, this one I think is probably makes the most sense for Scott to answer. The question is, why would an employer consider dropping their health care coverage and sending their employees to the public exchanges instead?
Sure. So there's been a lot of debate and discussion about that. And I mean, the bottom line answer is if you're an employer, a small employer that has a workforce that has most of your employees with household incomes in the FP under the 400, then perhaps it makes financial sense to just drop in a simple description. The challenge comes around where it don't get its household income, not just that specific employee's income. So if somebody's making a decision as an employer to drop coverage thinking that they have all these employees who are only making $30,000 a year and they would expect them to get huge subsidies, but if it turns out that they have spouses that have well-paying jobs, and that's going to turn out to be a huge disadvantage for those folks, and you get into all these privacy issues about asking employees about household income, et cetera, et cetera.
Thanks, Scott. That makes sense. And this one may make sense for you to answer. What can physician practices do to educate their patients about either getting insurance or what the expectation is for their share of the cost?
Well, it's very difficult for physicians because they have such a personal connection to their patients. But there's a statistic out there that says that 36%, once a patient leaves the office, if they haven't paid anything toward their responsibility, 36% of those patients will not be paying. And so it's really important for the physician staff to understand how they can guide people to either becoming insured or to help them understand what it is that is their responsibility. And that that's a very unique and difficult conversation for physician staffs to take on, but is really critical. The physician doesn't want to spend time in the precious minutes of a physician visit with a patient talking about the cost of their care. But I think if the staff is well educated about it, they can offset any need for the physician to discuss it with the patient.
Great. Thank you. Let's take one last question and then we'll wrap it up for today. If health plans are to assist, my concern is that Anthem and Blue Shield have been threatened with a class action suit for false provider lists. What is being done to address this concern? Ann or Scott, do you have any thoughts on that? I've got a thought or two that I can share as well, but let me ask you all first.
Hey, go for it, Carrie.
Yeah, I think, Carrie, you're best qualified as an attorney to respond to that.
So I'll put on my health law attorney hat and just give you sort of an off the top of my head response to that. I mean, I think what we're seeing is a real emphasis on health plans being very clear in their marketing materials. You know, that's really the basis of these lawsuits. You know, that the provider lists are misleading or incomplete, and it's causing confusion with the consumers. So, you know, I think that the best thing to be done to address that, and there's much more of a focus on actually very precise and very accurate marketing materials, and we'll see the government, I think, really starting to crack down on that. Well, let's go ahead and wrap it up for today. This was an excellent presentation. I really appreciate everyone's participation. I want to let you all know that, again, this presentation is being recorded and you can refer back to it. We'll post it on our website. We have our contact information listed up here, both for Ann and for Scott. For those of you who don't know, Healthcare Solutions Connection is a network of independent experts who have niche expertise in various aspects of the healthcare industry, and we put that expertise to work in an integrated and holistic fashion to better serve our clients in the healthcare industries. So please feel free to reach out if you have any follow-up questions. For now, we'll close things out, and I wish you all a great afternoon. Take care.